in the audience has actually ever even seen, let alone use, an optical pachymeter. Well, what are the limitations of AMSA-Krumak? So first, I just want to give you an example. This is a 35-year-old with an apical PAC of 485, a mean K of 54, and an RX of -3, -150, axis 88. So by AMSA-Krumak, what stage would this be? Well, if you look at the RX, it's stage 1, but if you look at the pachymetry, it's stage 2. If you look at the K, it's stage 3. So when you hear someone at a meeting say this is stage 2 or stage 3, it's a meaningless term. I have no idea what they're really talking about. Let's look at another example. Here are two patients. On the left is an 18-year-old with a PAC of 410, a mean K of 52, and an RX of -8. On the right is a 47-year-old with a PAC of 544, a mean K of 485, and an RX of 525. My guess is no one listening would think these two are similar, nor would it be likely that you would approach them in a similar fashion. But on AMSA-Krumak, they're actually graded both as stage 2. So again, a very limited staging system. The other limitation is that it relies on apical thickness. Again, it was developed with an optical pachymeter. Picture on your right is a corneal thickness map. The apical reading is actually 520, but this cornea actually thins down to 499 at the thinnest point. And again, when dealing with ectatic disease, it's the thinnest point that conveys more severity of the disease than just taking a reading at an arbitrary apical center. But the biggest limitation is that it doesn't take the posterior corneal surface into account. Again, it was developed 70 years ago before we had any ability to even image the posterior surface. It was also developed at a time where our only therapeutic options for moderate to advanced disease were either rigid contact lenses or penetrating keratoplasty. And those two are used for late stage disease, when you have significantly decreased vision that can't otherwise be corrected. So for AMSA-Krumak, the only thing that was really important was the anterior surface. Those of you are probably familiar with the Belin display shown here, but this is moderately advanced keratoconus. If you look at the second vertical column, it's a big posterior ectasia. If you look at the right side, it's an abnormal pachymetric progression. And if you look at the final D, though it's hard to read, it's a little bit below 8 standard deviation outside the norm. But if you look at that first column, which is the anterior surface, it's completely normal. AMSA-Krumak doesn't recognize this as disease. This is true disease. It's not a term I hate, form first or suspicious. It's true disease. It's subclinical because the patient's asymptomatic, but it's true disease that otherwise is completely missed by a classification that's limited to the anterior surface. So why do we need a new system? Well, again, as I already said, AMSA-Krumak was developed when we only had really rigid contacts or penetrating keratoplasty. We now have a number of different modalities, but the real game changer was crosslinking. Because crosslinking is the first treatment that has the ability to slow, stop, or perhaps even reverse the ectatic process. Now, this is not just me saying it. In 2015, you're probably all familiar with the global consensus of keratoconus and ectatic disease. That was a product of the 4 multinational cornea societies: Asia Cornea, Pan Cornea from South America, U Cornea from Europe, and the Cornea Society mostly from North America. And what did they conclude? Well, one of their conclusions on the definition and diagnosis was that the following findings are mandatory to diagnose keratoconus: abnormal posterior elevation, abnormal corneal thickness distribution, and clinical non-inflammatory corneal thinning. If you notice, what's missing on this is a change in the anterior surface. They also stated that the best current and widely available diagnostic test to diagnose early disease is tomography, be that either Scheimpflug or OCT. And finally, that posterior corneal elevation abnormalities must be present to diagnose early or subclinical disease. So many viewers, I said earlier, are probably familiar with the Belin ambrosia enhanced dictation display, commonly called the bad display. And the bad display uses something called an enhanced reference surface. What that enhanced reference surface is a modified reference surface to further accentuate the ectatic region. And what the enhanced reference surface does is it takes actually a variable 3 to 4 millimeter zone centered on the thinnest point, and it's a long formula how we decide the exact size of the optical zone, and it removes that from the best sphere computation. By doing that, it normalizes the reference surface because that area that we remove represents the bulk of the ectatic region. Now, for the bad display, that works because we're actually not trying to describe ectatic disease, but accentuate the pathology. But we looked at that and said, well, if removing that exclusion zone works by normalizing the reference surface, then we should just look at that exclusion zone as that represents the bulk of the ectatic region. Now, as I said, that exclusion zone is actually variable between 3 and 4, and it goes by a fairly detailed analysis. But on patients with true keratoconus, it almost always is actually a 3 millimeter optical zone. And then we came up with a new way to classify disease. And what we did is we took Amsler-Krumak, which people were familiar with, and we looked at how they divided the K readings, or the anterior surface. We looked at our fairly large normal population base, and we determined both our average and standard deviation and what that would be according to the anterior surface using Amsler-Krumak. And we then carried that across to the posterior surface and to corneal thickness, or minimal corneal thickness. Sounds confusing, and I try to explain it. It will be confusing, but the machines do this automatically for you. Another limitation of Amsler-Krumak is, if you think about it, everyone has disease. Everyone is at least stage 1. Now, clearly, not everyone has ectatic disease. So we also added a stage 0 to our classification, which better reflects a normal cornea. The A value stands for the anterior radius of curvature, taken from a 3 millimeter zone centered on the thinnest point. The advantage of this, as opposed to the old Amsler-Krumak or Kmax, is that it's not a single point reading. It's a average curvature from a 3 millimeter zone, and again, as opposed to Amsler-Krumak, which is apical, it's centered on the thinnest point, which is pretty much where the cone is located. B stands for back, which is posterior radius of curvature, again from a 3 millimeter zone centered on the thinnest point, and C is minimal pachymetry. D is not a machine-generated number, but is user entered if the user wants to enter it, and it's distance visual acuity. So again, we have 5 stages, 0 to 4. So why do we use radius of curvature when everyone's really more familiar with diopters? Well, when you start looking at the posterior cornea, in addition to the anterior cornea, diopters is not really very intuitive, because the posterior cornea is a low power minus lens. And if someone was to say, well, my anterior surface is 55 and my posterior surface is -7, that doesn't really relate to us. We have a hard time knowing really what that means. Radius of curvature has many advantages. One, it's independent of index of refraction. In different machines, keratometers and different topographers and tomographers actually use different index numbers. And it's a constant. It's a physical property. It's not an optical property. And it's directly related to the anterior surface, and posterior surface can then be compared. So as I said, it's confusing, but the machine does this actually automatically for you. And you will find this on what's called the topometric keratoconus staging display. And here I just extracted the part that relates to the ABCD classification or staging. It actually gives you 3 separate bits of information. The least useful is the actual classification you see down below. The classification is useful if you do studies so you can group patients into different classes, but it's the least specific to that individual patient. So if we look here, we see it says A0, B4, C3, D0. A0 means it's a normal, or at least it falls in the normal range on the anterior surface. But B4, it's a very large posterior ectasia. C3 is a moderately thin cornea, but D0 is normal visual acuity, and it's normal visual acuity because, again, that anterior surface is normal. We show that graphically, which actually gives you a little bit more information. You can see, again, the anterior surface is very close to 0. The posterior surface is actually greater than 4, so it's a very marked posterior ectasia. Corneal thickness, or minimal corneal thickness, at 3.1, and distance visual acuity is a little bit decreased, but still within that normal range. The most specific information to that patient is actually shown here, which is the exact numbers. This is the anterior rays of curvature, which is 7.6, posterior rays of curvature 4.82, minimal pachymetry at 381, and distance visual acuity at 2020. So let's look at some examples here. This is a normal eye. Here you can see the form map composite, completely normal eye. Here you can see that topometric keratoconus staging, and then I just blew up the part that relates to the ABCD, and again you can see every parameter is within the normal range, and it's a completely normal eye. Let's look at some very early ectatic change. Here, if we look at the form map, we see what looks like a pretty normal anterior surface. If you look at the posterior elevation, there's a very early area of a positive island elevation here, and the cornea is minimally thinned at 492, but still within what would be considered the normal range. And again, the blow up of the ABCD classification. You can see A1, B0, C0, D1, very, very early change. But you can see here again that these numbers, 1.2 and 0.9, are actually very close to each other. So the classification is actually less informative than looking at actually the graphical analysis. Here is moderately advanced keratoconus. I don't think anyone would miss it here. You can see again an anterior ectasia, a more prominent posterior ectasia. Cornea is thinned down to 470 here. And again, if we look at the classification or staging here, you'll see again A2, but again, more information by looking up at the graph. You can see that it's almost at the 3 level. B4, it's actually beyond really the 4 number, very big posterior ectasia. Moderately thin, it's C1, but again, you can see where it falls within that class. And because the anterior surface is abnormal, we have a decreased visual acuity to 20/125, which again is a D3, but actually graphically 3.2. And here is very advanced disease. Again, I don't think anyone would miss it here, but you can see again, the A parameter is past 4, the B parameter is past 4. The corneal thickness is at C2, which is 432, and visual acuity is 2100. So again, A4, B4, C2, and D2. But again, the most useful information to that individual is here, but the graphical analysis really shows you more where they fall within that stage. So that was really kind of a backup to why we developed a progression display. And when we first developed the classification, we knew in the beginning our real ultimate goal was to utilize that information to develop a progression display. Now, often I get questions, well, we have the bad display. Why do we need a progression display? Can't we just follow the D value or the bad display? Well, the bad display was designed specifically to separate normal from abnormal. It's designed as a refractive screening program. While it is very useful, and from what I've been told, it's the most widely used screening program and actually worldwide, it is not specific for hepatic disease. It analyzes more of a risk analysis for refractive surgery. Now, it can be used as an inclusion criteria for keratoconus studies if you exclude other comorbidities. The final D shows deviation from normal, but not necessarily progression of disease. And we'll give you some examples of what we mean by that. Now, the ABCD progression display was designed specifically to follow and document progression of disease. It's based on one-sided confidence intervals. It allows for documenting progression in spite of a stable anterior surface and/or a stable Kmax. And like the ABCD classification, it also evaluates each anatomical layer individually. Now, here's an example of why we say that the bad is not really specific enough for progression of disease. So these are three abnormal bad displays. The one on the lower left is post-refractive, and you would want it to be abnormal. It's not a normal eye, so it is not specific, again, for hepatic disease. The upper right is hyperoptic LASIK. Again, it's going to be abnormal, and it should be. And the lower right is endothelial dysfunction. You can see actually here a flattening of the pachymetric progression, which is what you typically will see with early corneal edema. And when you see that, you will often see some changes on the posterior surface, but again, not specific for hepatic disease. So the bad display does exactly what it was designed to do, and that was to separate normal from abnormal, but again, not designed to specifically document progression of hepatic disease. And again, I go back to the 2015 consensus document, because again, when this came out, and I was part of the group that wrote this consensus document, it was kind of our motivation to begin to look at new ways to kind of describe hepatic disease. And what the consensus document conclude about progression? Well, they said ectasia progression is defined by a consistent change in at least two of the following parameters: steepening of the anterior surface, steepening of the posterior surface, or thinning and/or increase in the rate of corneal thickness from the periphery to the thinnest points, and that these changes needed to be consistent over time and above the normal variability or measurement noise that we see in whatever system we are using. If we look at prior progression parameters that were in the literature prior to the ABCD, and we look down this long list, other than pachymetry, every single one of these is an anterior surface parameter. Spherical power, spherical component, Kmax, Kmax minus Kmin. These are all anterior surface parameters, which again are limited to the fact that you have to have already had changes on the anterior surface. In other words, you have already had to have loss of vision, and then that loss of vision on the anterior surface actually has to get worse before you can document progression. And our reliance on Kmax, I think most people now in their refractive field and in crosslinking really realize the limitation of Kmax. But our reliance on Kmax, both as an efficacy parameter and as an indicator of progression, has resulted in irreversible loss of vision and also delayed intervention. I know in the US, I don't know about in Canada, but currently our insurance companies mandate that we document on the same system at least a 1 diopter change in Kmax before they will actually reimburse for crosslinking. In other words, you have to have loss of vision and you have to have lost more vision, which is kind of not the way we normally do medicine. Medicine should be trying to prevent sequela, not treat irreversible sequela after it occurs. So in order to use the ABC, it's really the ABC, because these are the machine-generated parameters, we needed to know when and if true change occurred. And to do that, we needed to determine the background noise, or the noise of measurement for each parameter. And then we're going to develop a staging or progression display that automatically determines if and when you have significant change. And we decided it was important that we actually look at the measurement noise in two different populations, a normal population and a keratoconic population. We all know, and it's not just with tomography, it's with almost any measurement, that the more abnormal the cornea or the eye is, the more variability is in the measurement. So for your older patients with clinically evident keratoconus, the noise levels from the keratoconic patient database are more appropriate to document progression. Additionally, from a clinical point of view, the older patient is less likely to exhibit rapid change, and the risk of observing or waiting is lower. But in that young patient, pediatric patient, or the patient with subclinical disease, very minimal change, the noise levels on measurement more closely match a normal population than those with moderate or advanced keratoconus. Additionally, in a younger patient with normal vision and subclinical disease, early detection of any change to prevent permanent visual loss is important, and also in the younger patient, the risk of waiting is higher. So we, again, did noise measurements both on the normal and the keratoconic population, and we determined what's called one-sided confidence intervals. One-sided because we're only interested if the cornea thins or steepens, not the other way. And we determined both 80% confidence intervals and 95%. And if you look down at these numbers, the red are the keratoconic patients, the green are the normal, and you will see exactly what you would anticipate. And that is the noise levels on the keratoconic are higher than the noise levels on the normal, which is what we anticipated. And this is the second iteration of the progression display. Excuse me. The progression display allows you to display up to 8 exams over time. It graphically displays on this first row the A parameter, again, anterior radius of curvature. The second row is B, or the posterior radius of curvature. The third is minimal pachymetry, C for corneal thickness. And D is distance visual acuity, which again needs to be entered by the operator. The confidence intervals only appear for the ABCD. There are no confidence intervals for visual acuity. You can mark when you have a baseline, what your baseline exam is. It'll default to the first exam here. If you notice the little blue, you're marking your baseline, and you'll see it shows up as your baseline exam here. You can also mark when you've done treatment, and treatment really relates to cross-linking. And if you mark that you've done a treatment, it will show up as a hatched line that you see here. And if you notice, the confidence intervals will not appear after treatment. And that's because those noise measurement confidence intervals don't apply after a cross-linking has been applied. We show both the 80 and 95% confidence intervals, both in the normal and keratoconic population. The solid lines represent the 95% confidence interval. The hatched line is the 80. Green is normal, red is keratoconic, and you'll see here, hopefully you can see my pointer. I'm looking at the second row, the B row. This is the 80% confidence interval for change. This is the 95%. This is the 80% against the keratoconic population, and this is the 95%. We additionally show 10 additional parameters in tabular format. These are parameters here. You'll see that the actual ABCD classification, the final bad D from the bad display, progression index average, ART-max, Kmax, Q values, and number of anterior surface parameters. These are basically a number of different parameters people have used in the past, or they can also wish to follow. So just shown in a little greater magnification. Again, you can identify baseline. You can pick any exam for baseline, but the system will default to the first exam. And again, on the far right, you can show when and if you've done a treatment. You can also choose which population you want to compare to, the normal population or the keratoconic. The system will default to showing both. When would you want to not default to show both? Well, if I have a very young patient with subclinical disease, often I will opt only showing the normal population. For reason being is I'm going to be more aggressive and not really risk waiting on that patient. And you may see statistically significant change against the normal population, but not against the advanced keratoconic population. And I'm not going to send, or I'm not going to have someone, let's say an insurance company or a malpractice attorney look at that and go, well, why did you treat the patient when they weren't at this level or that level? Because it's not the appropriate level for that patient. So here you can see, again, it will default to showing both, but you'll see on the upper map, we chose only to show the green or the normal population, and the lower one, we chose only to show the keratoconic or the red population. Most of the time, you'll leave it to default to both. And I already mentioned, again, I'm just showing it in a little better magnification, that if and when you indicate the treatment, and again, treatment usually means cross-linking, those confidence intervals will go away. So they only apply to pre-treatment eyes. So let's look at some clinical examples of the utilization of the progression display. So this is a 15-year-old with advanced keratoconus. If you look down here, you can see the ABCD classification, A3, B4+. So again, this is advanced disease. If you look at the bad display, it's 11, or it goes up to almost 16. So we're not talking about early disease here. And if you look at Kmax, you'll see it goes from 56 all the way to 64. Now, this is not someone that we stood here and watched get worse and worse. The progression display can go back and look at historical patients. So this was actually someone from, if you look here, the first exam was 2010, so almost a decade before the display became available. But again, you'll see that every parameter here continues to get worse. So again, you'll see again, and this is fairly advanced disease, even though it's a fairly young patient, but well past, even by the second exam, well past the 95% confidence interval, both in the anterior surface, on the posterior surface, and by the third exam, corneal thickness, again, well past the 95% confidence interval. So this is clearly progressive disease, but again, you could have picked that up by just looking at Kmax in this patient. But the real utilization and the purpose is really something like you'll see here. This is a 15-year-old with very early keratoconus. If you look, actually, the classifications are still all under the normal range. If you look at the bad D values, they are obviously in the abnormal range, 2.92, 3.34. I want you to look at the Kmax values, 46.1, 45.5, 45.8. No significant change. Actually, I got a little bit better. No significant change. This person, at least in the US, would not be approved by an insurance company to get Crosslinking. They have good vision. They have a normal anterior surface. Well, look what's going on the back surface of the cornea. Okay, first exam, second exam, past the 80% confidence interval, and by the third exam, well past the 95% confidence interval. They're getting progressive ectatic change, but it's picked up early enough and prior to changes onto the anterior surface. This is true progressive disease, in spite of the fact that Kmax and visual acuity are stable. Here's another example of a 16-year-old. Again, not as early as the last patient. You'll notice, again, fairly early classification. Bad D of 2.77 going 3.45. But again, look at Kmax, 48.9 to 49.8, just under the requirement by most insurance companies to approve cross-linking. But if you look, you'll notice on the anterior surface, against a normal population, it's well past the 95% confidence interval. But look again what's going on in the back of the cornea. So these are two parameters, actually three parameters, all ABC parameters, all go past the 95% confidence interval against the normal population. And actually, except for the anterior surface, they go past it even on the more difficult to show keratoconic population, in spite of the fact that they don't meet requirements based on Kmax. Again, waiting till someone progresses till they actually lose more vision is counterproductive. And here is actually an example of the bilateral display. I normally don't recommend it. I just want to compare the two eyes. Again, you'll notice no changes on Kmax. Actually, Kmax here even got better by almost 2 diopters. And you'll see no significant change on this eye. But look at this eye. Again, Kmax actually lessened by 2 diopters. But again, look at that back surface. Progressive ectatic disease, in spite of the fact that we see no change in Kmax. Now, it's not just early disease. This is an example of moderately advanced keratoconus. If you look at the bad Ds, we're looking at values in the 7s. This is not, again, early disease any longer. But look at, again, the Kmax values, 51.2, 52.1, 51.9, 50.3. None of them reach the 1 diopter criteria. But let's look again. The anterior surface looks relatively stable, and that's also why we don't see significant changes in Kmax. But again, by the 3rd exam, we're seeing changes. By the 4th exam, we're past the 80% confidence interval. And if you look at corneal thickness, by the 4th exam, we're past the 95% confidence interval. So again, changes in spite of the fact that our anterior surface is not showing significant change. So how do we diagnose progression? Well, we recognize that there's a disassociation of clinical progression with changes in Kmax. Again, changes on the anterior surface are a late part of the disease. We now have a tomographic-based classification system that looks at and evaluates all the anatomical layers, and a tomographic-based progression display that documents when we have statistically significant change. And I already said it may be used on older historical files, so you can actually go back and review past information with the new software. I had mentioned right in the beginning that if you indicate that you've done a cross-linking, those confidence intervals will fall out because we don't have, or we didn't have, noise measurements after cross-linking. And progression parameters after cross-linking have not been known. So as I said, those confidence intervals will fall out after you indicate a cross-linking. The next version of the Belin ABCD progression display will incorporate post-cross-linking parameters. And busy slide, this was some research I did in conjunction with the Elder Institute in Zurich. It was going to be presented and was accepted to be presented at the now no longer being held ESCRS meeting in Amsterdam. But briefly, what we did is we looked at 41 eyes of 41 patients with an average age of 30, basically 33, with an average post-cross-linking follow-up of 13.5 months with a range of 9 to 23. The average final D, these were fairly advanced, of 9.26 with a range of basically very low value all the way up to nearly 19. And again, similarly to what we did with the normal and keratoconic, we determined one-sided confidence intervals at the 80 and 95% level. And this is what the findings were. We don't show you what the prior normal and keratoconic, but these are significantly noisier measurements, which is something we would anticipate after cross-linking. So this is a mock-up or the beta version of what the software will look like. We will show, again, the post-cross-linking gates will be shown in blue. The same hatch line will be 80%, solid line will be 95%, and they will only appear at 10 months after cross-linking. So again, hopefully this will assist, because we do know that some patients who have been cross-linked do and probably will need repeat treatment sometime in the future. So that concludes. I think I pretty much stayed on that 40-minute time frame I was given, and I believe we're going to try to open up to some questions if there are any.
Great. Well, thank you so much. That was. I wish we had extended the time to more, because this is very informative. I think it was very high yield slides, and your presentation was very, very informative. I think one thing that I think is evident to most of the attendees is that we've got to start talking amongst ourselves about our patients in a little bit different way. And so you mentioned the older classification systems and why that may not be most appropriate. And you suggested the newer classification systems. What is your advice now to some of the trainees who are on the attendee list in terms of how they should be learning to talk about our ectatic patients?
Well, I'll tell you, I don't know if that's what you're asking, but what I do with the progression display, I mean, explaining things to patients is difficult, to say the least. They have no idea what you're really talking about. However, if you show them the screen or show them the printout, and particularly if you get rid of the, pick the one that you want, the green or the red, depending on the patient's severity and the age, and you just show them, look, this is your change, and that's something that, even though they don't know what you're talking about, they visually can see. So I think it's very useful for, I don't want to use the word patient education, but to have the patient understand why you're suggesting a treatment. As far as the trainees go, I'm really hoping no one is still teaching Prumac. I mean, if you were an oncologist, I don't know anyone would be teaching you a 70-year-old classification for breast cancer. I don't know why we continue to teach something that is so outdated.
Okay, and when do you expect this next version of the progression display with the cross-linking information to come out?
So, very good question. It was earmarked to be released at ESCRS.
Okay.
When we looked at the numbers, I am concerned that the noise levels are much higher than I would have anticipated. Now, from a clinical point of view, that is good or bad. It's positive in the fact that we're not going to be doing unnecessary retreatments, but it's bad is that we may not pick up patients who really need to be retreated. And my concern is that, again, we were dealing with somewhat of an unknown. We don't really know what happens post-cross-linking as far as tomographic measurements go, or noise levels. We used, as I said, arbitrarily 9 to 23 months, with an average of just over one year. The same group that I worked with, and actually we have another group also, we're going to be looking at two-year data. So I'm a little hesitant of releasing the next iteration until I'm a little bit more comfortable with the noise levels. On the positive side, many of those patients who were part of that early study, which was 9 months to 23 months, a vast majority of them are already at 2 years now, because this was done almost a year ago. So they're in the process of trying to call those patients back.
Okay.
So the other thing is Oculus is extremely slow sometimes again, but the beta, I have the beta software. A few other sites are evaluating it. It works very well. I want to really be a little more comfortable with our noise levels, because that really relates to what the confidence intervals are.
Okay. Okay, that makes a lot of sense. With respect to, you mentioned you don't like the term form first, and so in our patients who are subclinical or for refractive surgery screening purposes, do you know if Oculus has efforts, or do you personally see utility of combining or bringing in biomechanics and bringing in epithelial mapping?
Okay, two separate things. I find, and hopefully this paper will be accepted. It's not. I'm far from the lead author on it, but I am one of the authors. I find epithelial mapping not very useful. This paper looked at a number of different imaging modalities, and epithelial mapping from not from a screening, but from describing the ectatic disease, actually showed the cone superior temporal in about 80%. It was the least useful of all the different modalities. I've never been a big proponent of epithelial mapping for a number of reasons, and one of them is also that the person who was a big proponent of it, all his initial papers were from one journal that he was an associate editor on. So to me, that's not a good, unbiased review of the papers. But as far as biomechanics go, I've not been a big user of biomechanics. We are in the process of, when I say we, I'm working with people who are big biomechanic people. We are in the process of looking at entering a single parameter similar to the ABCD, an additional parameter, a fifth parameter, to the classification, which is a lot different than the progression. But we're at least looking at adding a biomechanical index to the ABCD classification.
Okay.
And that's something where I'm actively doing right now.
Okay. And and I know you're very heavily involved with this, and you have certain insight that many of us do not have. What excites you about the next couple of years in terms of diagnosing and following ectatic patients?
So here's my so I'm showing the it's not my title slide, but my thank you slide. So here's my bias. First, I should say, while I'm a consultant for Oculus, I get 0 for developing any of this software, which most people think is crazy, but that's true. But the last thing on the slide says CMO, CLXO. So CMO is Chief Medical Officer. So I serve as Chief Medical Officer of a epi-off crosslinking. So to me, one of the most exciting things is the potential to see or to prove whether epi-off is actually an effective way of stabilizing ectatic disease. Because what we see with the epi-off patients is not what we're seeing with the epi-on as far as that healing and haze and that long period of visual rehabilitation. We obviously have to show in a well-controlled study that it's also safe and effective. Well, we know it's safe from our earliest studies on phase 2. But it would be very interesting to see if and when, again, we can show that this is effective, because what it will eliminate is that long healing period that we have to be concerned about with current epi-off crosslinking. So it's very difficult in the first few months to really kind of determine whether you're being effective or not. And I'll go back to Kmax. Kmax was originally looked at as a good efficacy parameter. Some people now are actually looking at, excessive flattening as being a complication. So Kmax is probably a secondary effect of haze and scarring, in part. So I think what's maybe exciting is what we're going to see in the future as far as stabilizing disease. That's kind of a crappy answer to your question.
Okay, thank you. And so, this software and the various upgrades that come along with it make this a very powerful tool. But at least in our part of Canada, this is a tool that's mostly that cornea specialists would be looking at. And the referrals we get that we have coming in, from other ophthalmologists, from our optometry colleagues, especially the optometry colleagues, it relies on things like a scissoring reflex they've noted on exam, or fluctuating refraction. What are your thoughts about this, this software, this ability to pick up ectatic disease being available more to the frontline people where the patients are coming through, as opposed to the cornea specialist, which is kind of later on.
Let me ask you a question. This may be somewhat different again between the US and Canada. How many of your optometrists have visual field machines?
I would say a lot, majority of them.
And why is that?
I would imagine because there's a lot of people, there's remuneration for it.
Okay, that's it. Okay. How many of them have OCT machines?
I think the same, it's quite a few.
And why again?
Same reasons.
Yeah. So if and when, and I hate going back to this, if and when an epi-on treatment gets approved and we're treating much earlier disease, suddenly the value of identifying that becomes similar to glaucoma and AMD, and I think you'll see a great increase in the utilization of this technology. But the biggest thing is they also have to introduce a more basic unit that can screen patients, not necessarily the advanced units that you and I probably have. But it seems to be, particularly with the primary care and with optometry, that if there's a reimbursement part to it, that they are more than willing to purchase the equipment. But right now, again, cross-linking is pretty much more late disease, where you don't really see the value of what's the value for someone to pick up a disease that most insurance, at least in the U.S., most insurance companies will not yet pay for.
Mm-hmm. Okay. And in the last few minutes, people in the audience can think of questions they may want to ask as well. What role does aberrometry play in your ectatic patient management? Looking at things like coma, vertical coma, helping that in terms of diagnosis, does that play a role?
As far as management, I'm going to say no. I think it's useful, and there are some people who are promoted that as a kind of a classification. But as my concern always, and this is a very well-respected friend of mine who's a very big proponent of an aberrometry-based classification system, is that the fact is, again, that it's going to be anterior surface-based. Yes, your aberrometry will be affected by the posterior surface, but to a minimal degree, again, that same reason, it's a cornea-aqueous interface. It doesn't really have a big effect on true aberrometry. So I think it's interesting. I think but I don't utilize it on a day-to-day basis.
Okay. All right. Any questions from the attendees? You can send it through the chat. And if you are thinking of something, there's an evaluation form that I've sent out through the chat too. It'd be great if you can fill that out. Any other questions? Okay. Well, Dr. Belin, thank you again very much for your time. It's been most informative. With your permission, I'd like to post this recording onto our YouTube channel for our. Thank you, for our attendees and our trainees to look and review later on, and for those that could not have made it, for them to look at as well. I appreciate your time, and again, it really is amazing and kind of perhaps rare in these times that you spend so much time and don't receive any remuneration, but for what it's worth, thank you so much for developing this. It's made our life a little easier, and for patients as well. I think it's definitely going to help them, and there's been as you've mentioned, there should be a change in the way we view this, and to be a bit more proactive and perhaps aggressive in tackling these cases. Thank you so much.
Thank you.
And have a great evening.
Take care.
Bye-bye.